the title of my talk, first of all, I want to recognize Edgar and Chris Plaskos both, who have been very helpful in putting this talk together. So thanks to you both for your assistance with all the data collection and helping with some of the data analysis as well. So we're talking about challenging tradition to optimize stability. And if we accept the premise that we want to optimize stability and that stability is important, then there are going to be times that we have to challenge tradition and we have to do things that might be considered by many to be unconventional, because you have deformities that sometimes need something beyond what is considered more mainstream. So we're going to do this talk in a few different parts. We're going to start with a recap of the BalanceBot technique for those of you that might not be familiar with it. This is the first of a number of questions we're going to ask and then hopefully answer. And the question is, if we modify alignment to achieve balance, what is an acceptable alignment range? We're going to talk about soft tissue release rates in a balanced knee with different surgical techniques. And then we're going to show a couple case studies and talk about what happens when we might vary the femoral or the tibial alignment. So this is the BalanceBot technique. It's a tibia first technique. Here we've made the tibial cut with a navigation technology. And then we put the BalanceBot in the knee, and the BalanceBot is going to go through a range of motion and give you a graph here that, let's do that again. There we go. It's going to provide a graph that is going to give us gap data throughout the range of motion. And for some reason, I'm not able to pause this here, so you'll have to bear with me. This gives us the gap data, and now this is giving us our plan. So on the bottom is flexion, on the top is extension, and it's moving the knee into a certain position so that we can balance the knee throughout the whole range of motion. After we do that, that plan gets sent to the OMNIBot. So this is the cutting guide, and that's going to move the guide into position. We're going to make all of our femoral cuts now. We put the trial femur on, and we put the BalanceBot back in now, and it's going to take you through a range of motion. And as we do this, it's showing you that for a 10 millimeter insert that we plan for, we have 10 millimeters in flexion and 10 millimeters in extension. So this is an ideal graph. It's an animation, obviously, but you want to see those lines being parallel and green, and that's going to give you a nicely balanced knee. So here's a real-life example, and on the far right is our plan. And if you look on the bottom of the screen, we have 11.5 millimeters. On the top of the screen, we have 11.5 and 12 millimeters. At the very bottom, it's showing us that we have an insert that is 12 millimeters. So this is a really good plan. We've got a knee that's balanced throughout the range of motion. As you look at this, as you go to terminal extension, so the gaps that we're being given is at 10 degrees. You see the line narrows as you go towards 0, and that's the effect of the posterior capsule. If you look in the middle now, this would be a varus knee. And to get this balanced knee that we have without doing soft tissue releases, we have 7 degrees of external rotation up at the very top. At the very bottom, the knee is flexed 2 degrees. And the result of that, since we've externally rotated the femur, we've increased our resection of the posterior medial femur. So there's two options here. If you're going to be a gap balancer, then you either have to do soft tissue releases to increase your medial flexion gap, or you have to rotate your femur and modify your implant position by modifying your bone cuts. So in this instance, we've decided to do it on the bony side and to not do any soft tissue releases. The consequence is that you're taking away 15.5 millimeters medially. Now the metal that we're putting back is 11 millimeters posteriorly. It's 9 millimeters distally. So we're under resecting the posterior lateral femur by a couple millimeters. We're over resecting a bit on the medial side. And then if you look on the far left, we've cut this knee in 3 degrees of varus. And that's the varus relative to the mechanical axis of the femur. So so 3 degrees varus, and then our resections are 13.5 on the medial side, 8 millimeters laterally, and again, the implant is 9 millimeters, so under resecting just a bit laterally, over resecting a little bit medially. The bottom there shows you a size 5. So a couple points here also is that by flexing the implant 2 degrees, it allows you to really fine-tune how you balance this knee. So if you didn't have that, then your flexion gap would be bigger, and it usually equates to about 1 millimeter per 1 degree. So if you cut this at a typical 0 degree distal femoral cut, then your flexion gap would probably be 14 millimeters instead of 12 millimeters. So then you would either have to increase your poly thickness or you'd have to upsize your femur. The difference between the femur is 4 millimeters between sizes. So if you upsize your femur, then you end up stuffing the flexion gap and you're chasing your tail. So the ability to flex the component by whatever you need to do can really help you to fine-tune your balance when you need to. So I would argue that those of you that are gap balancers probably already do this, and you just don't know it, because if you're using traditional instruments, you've never had the ability to quantify the numbers of what you're actually doing. So you may well have put a femur in 7 degrees of external rotation, just not known it, and you may have resected 15 millimeters of medial femur and just not known it, and you probably have. So as crazy as this might sound, again, I'd say that many of you probably have already done this. And if you're a measured resection surgeon, then this really sounds crazy, and you'll have to listen more to my talk. But this is the choices that we make between soft tissue releases and bony cuts, and we'll learn more about it as we go through the talk. So the question that comes up next is, how do we know if we're going to make a commitment and do this kind of planning and plan for this non-mainstream alignment? How do we know that any plan, let alone this plan, is going to give our patient the function, the satisfactory outcome, the range of motion, the longevity that we want for our patients? So I'm going to answer that in part by talking about a couple conventions. So let's talk about kinematic and mechanical alignment. So we know that from this study out of Mayo Clinic at 20 years, looking at mechanical alignment of plus or minus 8 degrees outside of a outside of a zero mechanical axis versus plus or minus 3 degrees, that there is no compromise in implant survivorship. So if you are comfortable going with some kinematic approach, you're on firm ground, and you're not going to sacrifice longevity of the implants. The next question is, how do we define balance? So is a balanced knee a knee that is super tight on both sides of the joint that has zero gap when you stress it and opens not at all, or is that a knee that's too tight? Do we strive for a millimeter gap medially and laterally in a balanced knee? Do we want 2 millimeters? Do we want a knee that's a little bit more lax laterally than medially, like in the native knee? And then do we want that in both flexion and extension? So these are things that that we're trying to answer. And with this technology, we generate so much data that we're now able to start looking at those things. And hopefully you were able to see Jeff DeClaire's talk last week, which was a great talk, and talked about targets and what we're really striving to look for in terms of outcomes and knee stability. So this is one of Jeff's slides. And if you look at the x-axis here, you're looking at flexion gap stability. So the absolute difference between medial and lateral side. So the lower left corner is balanced within 1.5 millimeters of the medial and lateral side in flexion. And on the y-axis, you have laxity in positives and negatives. So on the negative side is lateral laxity, and on the positive side is medial laxity. So what we're seeing here is if you have a knee that's a little bit more lax laterally than medially and is well balanced in a flexion gap, then those patients have on average about a 10-point improvement in their Coues pain score if you're in that group compared to if you're outside of that box, which is very significant. If we look at this group here, which on the x-axis is the same flexion gap that I just showed you within 1.5 millimeters, and on the y-axis is mid-flexion stability. So that's from -1 degree, so a tight mid-flexion, to 2 millimeters of laxity. If you're in that rectangle, again, you're going to be about a 10-point improvement on your Coues score compared to patients who are not in that group. So it tells us that, yes, balance is important. A better balanced knee is going to do better, and helps us to understand maybe what kind of balance we're looking for and what balance really means. So we talked about that alignment does not impair longevity. And the next question is, does alignment affect patient outcome? So to answer that, we looked at a number of variables. We looked at femoral varus valgus, internal and external rotation, tibial varus valgus, femoral valgus relative to the mechanical axis, femoral rotation relative to the posterior femoral condyles, long leg alignment in flexion and extension, and then we looked at our Coues data for 181 cases. So we came up with this histogram, and if you look, these are all femoral resections. So on the left is coronal resection, and on the right is femoral rotation. So we look at from 5 degrees valgus on the left to 5 degrees varus on the right, and then on the right graph, -6 degrees, so that's 6 degrees internal rotation to 10 degrees of external rotation. And instead of calling them inliers and outliers, we're talking about conventional being in the blue and alternative alignment in the pink. And we broke it out to ±3 degrees in the coronal plane and -1 to 6 degrees of external rotation in terms of femoral axial rotation. And we looked at the difference between those two, and if we break that out across the Coues spectrum, we see that there's no difference in scores between either group. What if we look at the tibial resection, or bring that into it and look at the hip knee ankle angle? And we did the same thing, and now this is coronal plane on the left and still rotation on the right, but it just includes the impact of the tibial cut. If that was something other than 0, it might change things. So again, looking at conventional and alternative alignment, defining them a little bit differently. On the rotational alignment, went up now to -3 because we want to take into account if you're going to cut your tibia in a couple degrees of varus. So again, if we look at the difference between those groups across the spectrum, we see there's no significant difference across any of the Coues domains. So the takeaway message here is that femoral component and log leg alignment did not correlate with outcome or survivorship. Balance does correlate with outcome. This doesn't mean that alignment doesn't matter, but it shows us that balance may well trump alignment with respect to outcomes. We need more data to determine if there's an actual limit on non-neutral alignment, so we don't have a position on that, but it's something we're continuing to look at. So the next question is, if we can modify alignment and the knee is balanced through component placement, does this mean that we're going to do fewer soft tissue releases? So we looked at this in another way. We compared the rates of soft tissue releases with a tibial first gap balancing, so with a balance spot total knee, versus a femur first measured resection TKA using the OMNIBotics, so using robotics but not using the balance spot. And then we compared outcomes pre-op and then at 6 months. So we had 4 surgeons, 3 tibia first surgeons, 1 femur first surgeon, a total of 1,340 cases. For the tibia first, we had 1,256 cases. For the femur first, 84 cases. And then we did a prospective subset of 114 patients and looked at the Coues pre-op and at 6 months. And then we compared this to a standard paper written by Chris Peters out of Salt Lake City, where he looked at 1,216 knees, and he broke his group into 3, varus, neutral, and valgus, and used ±2 degrees as his determining variable with respect to which groups people were assigned. And then he cataloged how many releases he did in each one of those groups. So for our data collection, in terms of quantifying the number of releases we did, we looked in extension, laterally, midline, and medially. And so laterally, posterior lateral capsule, arcuate ligament, LCL, popliteus, IT band, straight up posterior capsule. And then on the medial side, posterior oblique ligament, posterior MCL, posterior medial capsule, semimembranosus. And then in flexion, looking laterally at the popliteus, the PCL in the middle, and then anterior fibers in the MCL and anterolateral PCL. And then we looked at how many releases were done. So blue is the Chris Peters paper, and he released 67% of his knees overall, and that was the 1,206 cohort that he had. Our femur first group was 40%, and the tibia first balance spot group was 21%. If you broke it down by deformity, it was considerably lower with the balance spot group in every category, 83, 50, and 28 for a valgus knee, 61, 27, and 10 for neutral, and then 63, 40, and 22 for a varus knee. And then if we look at our own group and look at how we did releases, blue is no surgical release at all, and the pink is the patients that did have a release. And if we look at a pretty wide group here, within this group of 6 degrees valgus to 11 degrees varus, the release rate was 20%. If you get outside of that group, the release rate goes up to 50%. So we had a pretty wide group where we had a very low rate of surgical releases. Here's our pre-op KOO scores, and there really wasn't much difference across the board before surgery between the release group and the non-release group. And then post-op, looking at KOO scores, quality of life, a change of almost 10 for the patients that had 0 releases compared to even 1 release. So we didn't quantify how many releases, just if you had a release or you didn't have a release. For sports, 11 points different. And then for symptoms, overall 4.4 release. The others didn't show a significant difference. So in conclusion, the tibia first total knee with balance spot reduced the soft tissue release rate compared to a femur first, as well as a femur first robotic, as well as a femur first conventional. Chris Peters group of 67%, and then the OMNIBot femur first group of 40%. Knees with soft tissue releases had less satisfactory KOO scores for quality of life, sports, and overall. And with the caveat that we need to look at this better and more thoroughly, and the degree of imbalance that needs to be corrected with bony resection versus soft tissue releases still needs to be defined, but something that is ongoing. So I want to finish up with a couple of case studies, and this first one is a 68-year-old woman with a BMI of 36, and she has a mild valgus knee with no soft tissue releases performed here. So you can see she's got about 3 degrees of valgus. She hyperextends a couple degrees. And here's her preoperative kinematics. Here's a preoperative x-ray. So -2 to 125 degrees. And her tibia cut was neutral. So the validation is the blue, so it shows I cut it in half a degree of valgus, so essentially a neutral cut. I cut the tibia at 2 degrees of posterior slope, and the reason I do that is I sacrifice the PCL, but I use an ultra-congruent insert. And so when you resect the PCL, you're going to increase your flexion gap, so I decrease my slope a little bit to offset the increased flexion gap that I'm going to get. So here's the planning screen, and we put the balance spot, we made our tibial cut, we put the balance spot in, you take it through a range of motion, and this is what you generate. And so you can see that this isn't the balance knee. You have 15.5 millimeters and 12.5 millimeters in flexion. The left side is varus, the right side is valgus. and extension at the top of the screen, you see we've got 13 and 14. So we need to do some work to balance this knee. So what the computer is going to help us do now is virtually position the femur to put this into a kinematic position. So by doing that now, we've got a 12 millimeter insert in the bottom right of the screen. Our flexion gap is 12 and 12.5 millimeters. So very happy with our flexion gap. Our extension gap is 11. And the reason that it's less is because I've moved the implant distally to tighten up some mid-flexion that we had. And I wasn't able to show you that on the video that I had early on, and I apologize for that. But counterintuitively, when you have a flexion contracture, if you move the femur proximally, like tradition has taught us to do, you actually generate more mid-flexion laxity. And I'll show you that with my next example I'm going to show you. But for this particular case, I moved the implant 1 millimeter distally. And for a patient that had some preoperative hyperextension, I don't worry much about doing that because I'm confident I'm going to get this patient to full extension, and it's going to give me a better profile throughout her range of motion to take up that mid-flexion laxity. So that's the right side of the screen. I've got a good graph. I'm very happy with my graph. Now, how do we get here? If you look in the middle, you can see that I've actually internally rotated the femur 4 degrees. And so again, we're at that place where you have to make a decision. If you're going to be a gap balancer, you have to do one of two things. You either have to release the lateral side, or you have to rotate the femur to give you the gap that you need. So by internally rotating the femur, I'm increasing my lateral flexion gap. Again, the alternative would be to release the soft tissue, but we've already showed you that the more soft tissue releases you do, the more pain people have, and maybe the less well they do clinically. So we're trying to minimize that. So by doing that, I now have a rectangular flexion gap that's 12 millimeters. My bony resections are 8 millimeters on the medial side and 10.5 on the lateral side. And again, remember our metal is 11 millimeters posteriorly. The knee is flexed 1 degree. You see that at the bottom of the middle panel. And now if we move over to the left screen, you can see that I've cut the femur in 2 degrees of valgus. My resections are at the bottom, 7 and 5.5 millimeter resections. And with a hypoplastic femur, frequently you're going to resect less bone on that lateral side anyway with a valgus knee. So that's not uncommon that you don't take much bone on that side. And so my limit for accepting valgus in a knee is 2 degrees. I think any more than that, it becomes a cosmetic issue, and patients don't like the way they look. I think it functions very well, but they just don't like the appearance of it, and that's important, and reflected in overall patient satisfaction for sure. So so I'm comfortable cutting this femur in 2 degrees of valgus. I'm also very comfortable cutting it in 4 degrees of internal rotation, which sounds crazy, but if you're going to be a gap balancer, then you have to do either the soft tissue release or the bony cuts. Now, the first time I did this, I will be honest, I did it with some trepidation. Looking at those numbers was a little daunting to me initially. And fortunately, it came after I had become accustomed to the system, to the software, to the instrumentation. And I decided to accept that rotation because that's what this particular knee needed. And I have never had a problem with patellar tracking doing this. And it doesn't come up often. I haven't needed to internally rotate the femur like this frequently. But if I'm encountered with this kind of a situation, I don't hesitate anymore. And I'm very comfortable that the patellar tracking is going to be just fine. Now, you have to assess your soft tissue envelope and make sure that you haven't created an unstable knee. So make sure that you're not internally rotating it because you've injured the popliteus tendon or you've injured, the MCL or any other tissues around the knee. So you have to really look at your soft tissue sleeve and make sure it's intact. But given that, then internally rotating the femur is what needed to happen here, because you had to shut down your medial joint space because of the imbalance due to the tightness laterally. So this was the plan. This went to the balance spot now. So this is the validation cuts from the femur. So our 2-degree valgus cut is what we planned for. A 0.5 degree of flexion as opposed to 1 degree flexion. 4.5 degrees internal rotation, 2 degrees flexion. And here's the final stability. So for our 12 millimeter plan, we have 11.5 and 12.5 millimeters in flexion. In extension, we have 12.5 and 12 millimeters. So we're within 0.5 millimeter all the way around with our balance. So I love that. You can see we're in 2 degrees of valgus, which we planned for. And I already told you I'm fine with that. Here's our post-op x-ray. Patella tracking is perfect. Range of motion 0 to 128 degrees. And her Q scores are 95 to 100 for pain, stiffness, and function. So that's a valgus knee. This is a 65-year-old farmer with a bad deformity, 21 degree flexion contracture, 14 degree varus contracture. For this patient, I ended up releasing his deep MCL. I took a little bit of bone off the medial tibia, and I released the posterior capsule. And you can see why. You can see he has, like, off the X-ray varus, really profound bowing, patellofemoral arthritis, some wearing away of the medial tibia. Here's his preoperative kinematics. You can see on the far left there that the graph stops at about 20 degrees because his capsule is so tight I couldn't extend him any more than that, even if I tried to push. It was pretty fixed. So here's our cuts, and in this situation, I cut his tibia in 2 degrees varus, and the reason for that was, there's a couple of reasons for that. It increases your working distance, so if you are going to address the soft tissues, it gives you some more room because of the tibia first technique. But also it gives you more room to put the balance spot in. The balance spot is 6 millimeters thick, and you need at least 6 millimeters to get this in and make sure that the balance spot is what's giving you the separation and putting tension on the ligament, not just the volume of the metal you're putting in it that's pushing the tissues out of the way. So you need to make sure you have an adequate amount, an adequate tibial resection, or you have to cut it in a little bit of varus to increase the gap a little bit more. And again, it's all part of our motivation to do less to the soft tissues. So again, we cut this in 2 degrees of varus. According to the literature, I think you're on very firm ground going up to about 3 degrees of varus. It's been shown that implant longevity is not impaired going up to 3. I cut in 2 so that if we do have some variances here, you can see I ended up cutting it 2.5 degrees of varus. So it gives you a little bit of flexibility there. So that's why I don't go right to 3. So I consistently cut in about 2. And then another thing that I look at in terms of who I decide I'm going to cut in 2 degrees of varus, if the way that you register the knee, you put the arrays in, you register the knee with a pointer with the computer so the computer learns the anatomy, and then before I make any cuts on the tibia even, I put the knee in about 10 degrees of flexion and I stress it. And that's to release the posterior capsule. But I stress it to see how much, how close to neutral I can get a varus knee, and the same thing with a valgus knee to see how close I can get without doing any soft tissue work. And if I can get the knee within 7 or 8 degrees of varus, then I would not cut the tibia and varus. If I do that, and let's say I have this 20 degree varus knee, and I can't get it within less than 7 or 8 degrees of varus, then I would cut that tibia in 2 degrees of varus. So that's how I make that decision who I'm going to cut in varus and who I'm not. So here's a crazy ligament balancing screen, and you can see the really tremendous asymmetry between the flexion and extension gaps. So this is the auto balance function. It got us 18.5 millimeters in flexion and 5.5 and 11 millimeters in extension, and that's because the posterior capsule was so tight that it really, you could see how it clamps that down. So, I'm sorry, this was not the auto balance function. This is just the initial ligament balance graph. And then with the auto balance, it gives me a graph like this. So now we have a balanced knee. You've got a 16 millimeter insert at the bottom. You have 16.5 millimeter flexion gap on both sides, 16 millimeter extension gap on both sides. But look at the midflexion laxity here. That curve just bows out, and you've got 5 millimeters of laxity on both sides of the knee. It's balanced, but it's loose as hell. So this is a knee that you would have to use constraint for, because otherwise, when he's walking in midflexion, his knee's just going to slop all over the place. And this is what I was referring to before. This is a patient that, early in my training, I for sure would have moved that femoral component more proximally. That's what we learned. And sure, it helps you to get your extension, but along the way to extension, by the way, you lost your midflexion stability and you have a super sloppy knee. So you can't do that. You can't move the femur more proximally because you'll have to use constraint, or you'll end up with a really unhappy patient. We'll talk more about that in a minute. The other things on the screen that we're looking at, we're in 3 degrees of flexion. We're 1 degree externally rotated at the very top. We're in 1 degree of varus with our femoral cut. And then look at our resections on the lower left. You can see the femur resection is 18.5 millimeters posterior laterally and 12.5 posterior medially. So what we did, paradoxically, was move the femur distally. So I kept my 16 millimeter flexion gap, but now I've moved the femur distally 3 millimeters. So I've got 13 millimeters of extension gap. I have a really nice graph now, though. Those 2 lines are parallel. I've completely fixed my midflexion laxity, so I'm not going to need constraint. And this is a patient that I kind of threw in the towel in terms of what has to happen to the posterior capsule. I didn't think there was any way I was going to get away without doing a posterior capsule release for this patient. And so giving into that reality, then I don't really care if I'm moving the femur distally and I'm making the extension gap tighter, because I'm going to have to release the posterior capsule anyway. And then I'm also confident when I do that, I'm going to get him fully extended. So I'm really focused on the shape of the curve between flexion and extension. So this is a much prettier graph. Again, the lines are parallel. My midflexion is resolved. And now we go back and look at the lower left resection level, and now my posterior resections are 13.5 and 8.5. So still a little bit over resection on the posterior lateral side for an 11 millimeter implant, but not nearly as outrageous. And so this was the plan. And now here's our cuts. So we cut the femur 2 degrees varus, 2.5 degrees flexion. Here's our external rotation and flexion in our anterior femur and the coronal plane, rotational plane. And then here's our final stability plan, 16.5 millimeters in flexion, 16 and 15 in extension. So for a really hard, badly deformed knee, we have great balance with no midflexion laxity. And here's the post-op X-ray. So you can see where I resected a little bit medial tibia. You can see he's in probably 5 or 6 degrees of varus. Patella looks perfect. And also you can see the tibia is cut in 2 degrees of varus, so you can see that's off a little bit. But he is one of the happiest guys you'll ever see. His KOO scores were 100 across the board. He's back farming. He loves his knee. I called him specifically because I was putting this talk together and I wanted to hear how he was doing, and he just couldn't say enough. So that's just another non-traditional way to approach a bad deformity. Again, sometimes an unconventional approach is what's needed. So the takeaway message here is going to be that joint balance may have greater effect on outcome than alignment. Tibia first technique with gap prediction results in significantly fewer soft tissue releases. Soft tissue releases are correlated with worse patient outcomes. And then going to end with a question. Can we use this data to investigate balancing trends across a larger population? So, thank you. Do we have any questions?
Yeah, thank you very much for the presentation, Dr. Lawrence. It's always fascinating to hear about that data. We do have quite a few questions, and I'd encourage people to send in some more as well. A couple of questions along the same line have come in around, you mentioned that you don't like to put the knee in more than 2 degrees of valgus routinely. But there are questions around what's your limit on internal or external rotation of the femur?
Yeah, so that's a common question, and I really don't have it. Again, I've just learned that if you're going to be a gap balancer and use this philosophy where you're going to minimize your soft tissue release, then you go with what the computer is telling you to do. And it's important to make sure your soft tissue sleeve is important. I can't overemphasize that. You really need to make sure that you don't have crazy rotation because you've cut the MCL or the popliteus tendon. But as long as your soft tissue sleeve is intact, I've gone up to about 10 degrees of external rotation, and probably 4 to 6 degrees of internal rotation is the most that I've gone. And these aren't common problems, but you for sure are going to see them, especially with a valgus knee with a hypoplastic lateral femoral condyle. That's going to be something that will come up.
Thank you. Well, we have a question precisely on that. That first case study that you presented, we have a question around, was there hyperplasia or wear on the PCA? Do you think that contributed towards the final 4 degrees internal rotation?
Yeah, I think that it did. PCA or PCL, you mean?
It says PCA, posterior condylar axis.
Oh, I'm sorry. Yeah. So that was for sure part of that. Yeah, and you see that with valgus knees.
We've got a further follow-up question to the external rotation around. How do you visualize the anterior flange cut using the system? And are you ever concerned about that cut? And I guess a corollary of that would be, are you concerned about the patellofemoral joint when you internally rotate? Yeah,
so as I already said, I'm not worried about the patellofemoral joint. I've done this many times. I've never had a problem with tracking. So, and the worst thing that would happen, I guess, would be you have to do a lateral release, but I've not needed to do that. So, I think the gap balancing technique puts the implant where it needs to be, and it's just not been a problem for patella tracking. And the other question was about the anterior cut. So, to your point, if you really externally rotate, then you could get into more of the lateral femoral cortex there, and you could end up with a lateral notch. So it is something that you have to look at, but you can see it on the computer. There is a sagittal view where you can rotate the femur 90 degrees, and there's an illustration of where your cut comes out. And so I look at it in two ways. On the far left-hand side, if you may remember, there's an outline of the implant that's drawn out. So you can see it's a curved line, and that's the outline of the implant. And then there's a shaded area, which is your actual cut. And so if you really externally rotate the femur, then sometimes you're going to need to flex it more so that your cut exits out the anterior femoral cortex rather than notches. So you might need to downsize your femur so that you can flex it 2 or 3 degrees, and then you won't have a notch. But you can actually see what you're doing as you're moving the femur, watching your cut. So I want to see two things. I want to see on the far left-hand side, I want to see the shaded area within the caricature of the femur, within the drawing of the femur. If you don't see it, if the shade of the cut goes off the screen, then you don't know where that cut is going to come out. It might come up, halfway up the femur. So you want to see that cut ends within that image. And then on the sagittal plane, when you turn it, you also want to see where that's coming out and see that it's coming out anteriorly. So if I meet those two criteria, then I know I'm not going to notch, and we haven't notched by paying attention to those things.
Yeah, that's a really good point about making sure you can see the anterior cuffs emerge from the bone on the screen. And just a point to add there, you can always, if you see it not emerging, you can go back and take further landmarked points of that anterior flange to make sure that you do capture that area.
Yes, absolutely. And that's easy to do.
Sorry, go ahead.
No, I just said that's easy to do.
Yep. So we have a question around your implant choice, around using the ultra-congruent deep dish, and whether you think there's any advantage there with this technique, as well as why you choose to resect the PCL, and whether this technique has any advantages around CL or PS.
So I think you can choose to not resect the PCL. You can use a PS implant, and you can, I'm sorry, a CR implant, and not resect the PCL if that's your choice. But if you do that, you have to be really careful to protect the PCL throughout the surgery. So if it gets injured, if it gets stretched, if it gets inadvertently damaged, then all of your balance spot data is irrelevant, and you lose all of your planning, and you're kind of flying solo. So that's coming from somebody who has. I've never done one by not resecting PCL. So I'm not saying that as a threat. Oh my God, don't do it. It's a terrible choice. I'm just saying if you choose to do that and that's your flow, you absolutely can. You just have to be careful that you don't injure the PCL. For me personally, the reason I a long time ago, pre-balance spot, decided to go to a cruciate sacrificing knee was because it's easier to balance. Once I decided that a gap balancing technique was a better way to do a knee, then I think it's more consistent. It's not a deforming. It takes out a potentially deforming force. So once I take that out, then I'm really just focusing with the median lateral side, and the PCL is completely taken out of the equation. And then I like the ultra congruent because I don't want to make a box cut, and so it gives me excellent AP stability without having to use a PS and make that bone cut. And I've had some bad experience previously with some designs with PS with soft tissue entrapment and patellofemoral crepitus. And that's another reason I try to avoid a PS implant. So for me, it was a compromise, and it was the best of all possible worlds. But that's my basic philosophy on why I use what I use.
Yeah, it's a really good point around protecting the PCL, because if that does get damaged during, say, the future resections, then the preoperative data you've captured is then compromised. Yeah, that's a really good point. We now have a couple of questions on implant placement. So the first one is around the tibial coronal angle. So you mentioned about how you would aim for a slightly more varus angle if the knee remained particularly in a non-correctable varus alignment. So the question is around confirming, so the majority of the time you'll target a neutral coronal tibial alignment?
That's correct.
Right.
Yeah.
And then a follow-up to that is around femoral flexion and AP translation. So can you explain when you would flex the component or when you would translate the component anterior or posterior? And do you have a limit for either of those two factors?
Well, yes. So you're limited by the patient's anatomy in terms of anterior-posterior movement. So at some points, if you move it far enough, if you've got a bigger flexion gap, if your goal is to try to decrease your flexion gap, let's say, and you don't want to use a 14 or a 16 millimeter implant, poly, you want to use, my target is an 11 poly for every case, even though I showed you two cases that were thicker, but I target an 11. And the reason is that the smallest poly is a 10, and I want to have a basement I can go down to. If for some reason I think the knee is too tight, I could just use a smaller poly. So in spite of all these things that we're doing that are amazing, and we're able to quantify things like we were never able to before, still there might be a time where you think you're, within a millimeter tight, and gives you that flexibility. So I target 11. Having said that, if in the planning screen for a given size, if I've got a 3 millimeter gap that I need to close down to match my extension gap, then I have three options. I can increase my poly thickness, I can flex the component, or I can move it posteriorly. So the first thing that I do is move the component posteriorly and then look to see if I'm going to notch. And if it looks like I'm going to notch by moving it straight posteriorly, then I'll start to flex it. And again, you get about 1 millimeter of closure for every degree of flexion. Now remember that the implants are 4 millimeters apart in terms of AP width for each size. So a majority of the time you're in between that 4 millimeters. So if you jump, for my 3 millimeter example, if I jump to another implant and say upsize to close that gap, now I'm a millimeter tight. And maybe that's a good solution, and then I move that implant 1 millimeter anteriorly to balance the knee. So it's a combination of the two. It's a combination of AP and flexion. But first, I want to try to get the size that fits ML the best, and then I'll use that size and work with it until I can't work with it anymore. And then I'll have to make a decision on whether I have to upsize or downsize the femur. But if I can work with that size femur that we planned for and we measured for, I'll move it posterior until it looks like I'm going to notch. And then it's impressive how many times, when you're going to notch, all you do is you flex it 1 or 2 degrees, and you look at where that cut's going to come out, and you're totally fine. And you're not going to notch at all once you flex it, because you've changed the angle that anterior cut is going to hit the anterior cortex. So you have to be looking at all those things, and once you see this a few times, it's going to click, and you'll start making those changes very quickly in your mind, and it'll become second nature.
Yeah, the ability of small movements in the femoral component, particularly to modify the balance throughout the joint as well as the anterior flange, is quite impressive. We do have another question around how you modified the extension planning angle in that second case. I think you changed it from 10 degrees to 15 degrees. There's a question around, could you explain a little bit more about why you did that and what your criteria is before you begin to change that extension planning angle?
Sure. So for the group, it might, if you didn't see that, it might be a little bit confusing. So I'll back up a little bit and just tell you why we generally collect our data at 10 degrees. So
I think you're still sharing your screen, so you could go back to the planning screen if you wanted to.
Okay.
Yeah, we can see that.
Let me, sorry about that. So we're talking about here. So for this slide, you can see that the data was collected in the extension portion at 10 degrees. And when we first started doing these in the cadaver lab, before we got FDA approval, we were using 0. And it was really hard to balance the knee at 0 because the posterior capsule would engage, things really tighten down extension. Even somebody who doesn't have a flexion contracture, the wall effect of the capsule just crashes in those two graphs towards the midline of this particular graph tremendously. And so we were ending up with mid-flexion laxity in knees because the data we were using to balance, that we thought we were getting a balanced knee, was distorted because of the posterior capsule. So that effect relaxes at different places in different people. So on average, we go at 10 degrees. Now, you can change that point, and here we're still at 10 degrees. But if you take your data collection point and move it to 15 degrees, which we did here, then you're on a wider portion of the data collection curve, so you're balancing the knee at a more realistic place for where the ligaments are. In this particular case, even though we went to 15 degrees, it still didn't get me the full 5 millimeters. I don't remember exactly where it got me, but I ended up moving the distal cut even more distally than I did at the 15 degree mark to get a parallel line here because its flexion contracture was so bad. But point being that Edgar was asking about was you can modify the point at which you're collecting your extension data to minimize your mid-flexion laxity by changing that point. And if that doesn't make sense, someone asked me a question about it, but I think that clarifies it.
Yeah, I think that makes sense. Thank you. So we've got time for one more question, and somebody's submitted a question asking about if you did leave the PCL, how do you think that might impact the balance in the knee with the balance spot? And do you think that balance would be different, or how would it be impacted on a varus knee versus a valgus knee?
So I'd be totally speculating because I've never done it, to be honest. But the PCL is probably going to tighten you up a little bit more in varus, and so I'm guessing that you would probably need to externally rotate the femur a little bit more for varus knee, and or you'd have to do more soft tissue work to get you to where you'd want to be. And for a valgus knee, I'm not sure. Maybe you would need to rotate it a little bit less with a valgus knee if you had the less internal rotation with a valgus knee. I don't know. I'd have to look at that in a cadaver lab and see what happens. I do know we have had visiting surgeons in our cadaver labs that are PCL preservers, and we have tried to do it their way, and maybe twice that I can think of. And I know both times it was challenging to balance the knee, and then we went ahead and just cut the PCL, and the knee just opened up and became much easier to balance. So my very limited experience is that it's way easier to do it if you take out the PCL.
Yeah, I think that's a fair point. It completely changes the forces internal to the knee. I would mention that it's part of the ongoing research within Corin to better understand how to balance the joint, particularly when the PCL remains intact. Okay, well, we've come up to the end of the hour now, so I'd just like to take this moment to thank Dr. Lawrence very much for his contribution to all of this work and for his presentation this evening. Thank you, Dr. Lawrence.
Well, thanks, and thanks everybody for joining us. I know there's a lot going on in the world, and everybody's life is kind of turned upside down. So we really appreciate you taking some time to tune in with us today. So thank you.